Welcome to Coffee with Professor Leif. We have today Dr. Rahul Upadhyay, the famous foot and ankle surgeon from Rajasthan Hospital Limited in Jaipur, and we have the honor of hosting the 𝗊𝗁 foot and ankle meeting in Jaipur in the month of October.
All right.
So over to Dr. Rahul.
Yeah.
If you have any queries about 𝗍𝗍𝗃, and then we talk about the 𝗊𝗁 meeting.
First of all, Professor, a pleasure meeting you.
My pleasure.
I have been informed about the product. Mr. Mohan has been very instrumental in introducing me to this. So I would like to hear from you, your experience about it, and when exactly do you suggest, because I am a foot and ankle surgeon, my focus is on talus. For the talus OCDs, which are probably not responding well to the initial microfractures, or which are too big to be doing that. Do you think that this is going to be the game changer?
Well, I think it may well be. So far our experience has been very satisfactory. Now, as you may know, we have the talus implant was our second product. It's been on the market for a couple of years. We do not yet have any publications. We have not yet any 2-year compiled follow-up data. But the report that we are getting from the field are positive. We have one case that was operated, I think, 6 years ago now, that is working phenomenally, and he's playing soccer. He has a perfect ankle joint. A 45-year-old guy playing soccer, actually. So that's exciting. So my experience so far is mostly based on the tibia, where our concept seems to work. We have excellent clinical results. I would say our clinical results are as good as any other way of treating these lesions. Our revision rates are extremely low, lower than really anything else. Rehabilitation is very quick. The kinematics of the knee and also of the talus is normal, as is to be expected, of course, since the implant is adapted to that. So we don't change anything kinematically in the joint. So our experiences are good, and well, I can't say they exceed my expectations, but they meet them. They meet my expectations.
So what do you suggest I can promise my patients when I treat them or when I offer them this surgery? So what should I tell them?
Well, I think you should tell them, I mean, in the talus, I mean, you had two kinds of lesion. Either you have the osteochondral hole in the cartilage and the void in oftentimes the medial corner, or you have the fissure and the great big cyst that exist. Now, both of them are in pain. I think the patients with the cyst, these cysts are under pressure, so they have oftentimes ache. They have a lot of problems from their foot.
It's a deep-seated pain.
Yes, precisely.
What is my option then?
Yes, well, I mean, if the implant fails, your options are either a total joint or future.
But I still have enough for the joint.
I would say, yes, I would. Now that depends a lot on the total joint that you're using and the individual case that you're operating on. But it's a good question, because no doubt the implant is let's say, it's not surface replacing. It as you see, we drill away a bit of the bone, and that has to be replaced. Whether you can do that with bone chips, because the hole in the bone will be largely contained. I mean, you can stuff bone chips in there and then put the total joint. We don't have the experience.
So that's good.
Yeah, well, that's true. I fear the experience is not, because, I mean, we would have revisions for this, as with any other device. That's orthopedics.
6 years and
Yes, that is encouraging. Yes, that is. And you know, we haven't had a single case of implant loosening that we know of, not a single case. We have shown using RSA technology that the implant it osseointegrates with bone and it stays put. So we're pretty confident that this will.
There are a lot of concerns about metal on cartilage discussed with peers. So what do you have?
Concerned about.
Metal with cartilage.
Yeah. That is the most common question we get. Now, my take on that, when we started, my experience with metal against cartilage stemmed from total knees. So in Sweden, we put these in without the patella button. Actually, 95% of all total knees that are put in Sweden are done without the patella button. And the revision rate of those knees are lower than the ones that get the patella button. So I mean, hyaline cartilage is okay with metal. You may argue that the patella joint is not as weight-bearing as the femoral-tibia joint. That's true, but now we've put in about 1,600 of these implants, and we have an 11-year follow-up. Our first patient is 11 years old with implant, and it's still working. He's doing the marcia longa in the Italian Alps every year, so he works perfectly for him. And we have other data showing that, provided that the opposing cartilage is good from the start, and that's why we, using our damage marking